Good afternoon, everyone. Thanks for coming in, joining online and in person. I would like to welcome everyone to Project Echo. This is a program that was started by Dr. Santos and Dr. Leka George, founded earlier this year. They host monthly sessions with specialists from the Health Science Center to educate primary care providers. For those on Zoom, if you are attending, please stay muted during the presentation. CME credits will be available for this event. For those online, you will need to sign in. There's a paper form in the front of the classroom as well, and there will be a little text message you need to send at the end of the presentation confirming that you were here. This program is federally funded by the F. Maria Hall Institute of Rural Health and the Telehealth Resource Center. And now I would like to hand it over to Gabby Perales to do the case presentation on.
Good afternoon, everyone. My name is Gabby. I'm a second-year medical student here at Texas Tech. And today we're going to be talking about some strategies for better patient care and advancing obesity. So we're going to go ahead and begin today with a case study. Actually, we'll review our objectives first. Hopefully everyone on Zoom can see now. We just started sharing the screen. So our objectives for today will be to, one, define obesity, review the incidence and prevalence of obesity, review the peripheral and CNS hormones that assist in weight regulation, review pathophysiology of obesity-related disorders, and review tools to treat obesity. So we're going to start with our case analysis. In this case, we have a 38-year-old female who is presenting for an evaluation of obesity management. So this patient reports struggling with weight since adulthood, particularly after having kids. She has experienced minimal success with caloric restriction and is currently not engaging in exercise because she has various time constraints that don't allow her to do so. She has kept a food journal, and she does think it's a little bit difficult for her to try and keep up with it every day. And she expresses interest in initiating long-term medical management for obesity. She notes that associated fatigue and infrequent headache have come along with the weight that she has gained, and she'd like to try and fix that as well. So her past medical history includes pregnancy and obstetrical care. She does occasionally drink alcohol every now and then, and she has had questionable history of previous seizures. She does take an oral combination contraceptive. She has no known drug allergies. Her previous treatments have included orlistat as well as a low-carb diet. And then her current diet as of now when she's presenting to the clinic includes caloric restriction. And like I mentioned before, she's currently not engaging in a lot of exercise because of time constraints. And she denies any eating disorders, MEN2, medullary thyroid cancer, arrhythmias, kidney stones, glaucoma, uncontrolled hypertension, or opioid use. On her physical exam, one thing that stood out a lot, and it goes along with what she is struggling with, is her BMI. She has a BMI of 32.75, which classifies her as an obese individual. Her examination was unremarkable, but she has a Epworth Sleepiness Scale that is elevated with a score of 14. Her social history, like I mentioned before, she does occasionally drink alcohol. She denies any recreational drug use and tobacco use and is currently not sexually active. Her family history includes hypertension in both parents. Her mother did have renal failure, and both of her parents had lupus. So in her assessment and plan, the first thing we wanted to go ahead and diagnose was her class 1 obesity. Things that were talked about included lifestyle modifications such as limiting processed foods and refined carbs, reducing her total carb intake to less than 150 grams a day, setting a regular weight loss goal of 10% of total body weight over 1 year, and engaging in regular moderate intensity physical activity with a goal of at least 150 minutes per week. We went over the 5 A's of obesity counseling, which is just a protocol to kind of go ahead and assess and talk to a patient about what they should do if they want to lose weight and what medications they should take, if any. So the first step was to assess her BMI of 32.7. She is currently eating 3 meals a day with some snacking and minimal exercise. We advised her to try and set a goal of losing at least 5% of her body mass within 6 months from the clinic visit, with at least 150 minutes of exercise per week. The patient did agree to this plan, and we initiated a trial of low-carb diet, less than 150 grams a day, with low-dose phentermine and topiramate. The option of intermittent fasting was also discussed, and the patient wanted to go ahead and use MyFitnessPal for 2 weeks, which is an app that you can get on your phone that tracks fitness and diet. And then we went ahead and tried and arranged a follow-up in 3 to 6 months. So as for her fatigue, a laboratory workup was ordered, which included measuring levels of her TSH, her free T4. We got a CBC and CMP, and as well as a sleep study ordered for that high value for her sleep scale. So her first follow-up, this was a 3 months. We said we wanted to follow up within 3 months, so this is the first follow-up. The patient did report a good tolerance of her prescribed medication. She did adhere to her low-carb diet, and she went ahead and tried the intermittent fasting out. She has been meeting her exercise goal of 150 minutes per week as well. Her BMI has slightly decreased from 32.7 to 31.8, but she's still in that obese category that she's trying to get out of. She was able to have a sleep study done and is waiting on a CPAP machine. We discussed GLP-1 agonists to help her lose weight, as well as setting a new goal to achieve a BMI of less than 28 over the next 18 to 24 months. Dietary modifications and exercise regimen were reinforced. As for her fatigue, she does report improvement in her energy levels. So a 1-month follow-up was what was the next step in helping this patient out. So as of now, I'm going to go ahead and hand it over to Dr. Drew Payne, but let me go ahead and give him a quick introduction before he comes up here. So he's originally from Amarillo. He earned his doctorate of osteopathic medicine from A.T. Stills University, Kirksville College of Osteopathic Medicine in 2013, followed by an internal medicine residency at TTU-HSC, which he completed in 2016. Dr. Payne is board certified in internal medicine and obesity medicine. His research primarily focuses on patient health at the clinical level, with particular interest in preventative medicine and obesity medicine. He is actively involved in several research initiatives at TTU-HSC, contributing significantly to the field of obesity medicine. In his addition to research, Dr. Payne plays a vital role in medical education. He teaches resident physicians through his role as program director at the internal medicine residency program. He also functions as an academic hospitalist and outpatient internist, providing both inpatient and outpatient care. In the outpatient setting, he partners with TTP Bariatric Surgery to run a weekly medical weight loss clinic, fostering a collaborative approach to patient care. Here's Dr. Drew Payne.
Thanks, guys. Okay, can y'all hear me okay? All right, thank you, Gabby, for those nice words. It's almost as though I wrote those myself. So appreciate that so much. So really, to go through some of these objectives and to dive deep into that case that Gabby presented, we kind of need to define what obesity is. So really back in 2014, obesity, the definition changed. Obesity was kind of viewed before that as more of a cosmetic issue, but in 2014, the World Health Organization came out and said, no, this really is a disease process and we need to focus on this as physicians. So we still use BMI for that. BMI is far from perfect on categorizing people into risk stratification. There's other scales out there measuring waist circumference, measuring body roundness index. I saw this recently, or BRI. So there's other things to look more and risk stratify the patient, but this is what we have right now. Overweight defined as 25 to 29.9, then obese above 30 to 34.9, and then class 1 obesity 30 to 34.9. Obesity class 2, 35 to 39, and class 3 obesity greater than 40. We don't use the old term morbid obesity anymore. We've gotten rid of that and now refer to class 1, class 2, class 3. You can for sure type in morbid obesity into your electronic health records and something's going to come up, but these are the terms that are used right now in literature. So really, if we look at what has happened over the last few years, is that our heat map really has expanded. And I don't know if we need to put it on. Okay. I'm not going to play, but what this is it basically shows a heat map of where we're dealing with weight at this current time. If we were to go through this and go all the way through 2018, you would see that really down in the southern portions and in the Midwest, we've had a large increase of our BMI from self-reported studies. The CDC puts this out every year, and it seems to be slowly getting worse over the past decade. There has been some states that have started to turn the corner. I think Colorado in the most recent map did show up green on here, so that's good for Colorado. But Texas is still right in the warmest part of that heat map. Just to kind of put that into words, in 2023, all states and territories had an obesity prevalence higher than 20%. So that's more than 1 in 5 falling into the obese category. Over the Midwest, 36% and South, 34% had the highest prevalence of obesity, followed by the West and then the Northeast. These kind of progress in their levels of severity, kind of down to the last one with 3 states, Arkansas, Mississippi, West Virginia, really having the highest prevalence of obesity with greater than 40% of their population. So that's almost half of their population. If we look at here at our center here, this is some studies that we've done over the past few years. And I think there's some wonderful residents in the room that helped do this last one. So congratulations to you all for helping us do that. Back in 2016 to 2018, we had a bigger in this study, we had some stricter inclusion criteria in the most recent one, but it shows that we had 24% in the normal weight, almost 30% in the overweight, and 46% in the obese category. If we looked at these numbers later in 2020 and 2022, those numbers have progressively gotten worse. So our normal weight category, we only had 19% of the people that were normal weight. Overweight category, 29.6, and then obese has gone up to 51%. So that's 80% of our patient population here in this area that really falls into that overweight or obese category. So if you're in the normal weight as a patient, you're really in the minority. So we all know as medical providers all the costs of obesity as far as your health goes, all the things that it can cause. But really, I wanted to put one slide on here just for actual financial cost that obesity can play a role in. I know cost of healthcare is often the conversation, and this slide starts to kind of sum that up for us. Medical costs in the United States, obesity-related medical care costs are estimated to be between 147 billion and 210 billion per year. Now that seems like a massive number to me, and also I'm amazed at the fact that we could say, hey, maybe we're 50 billion off on this. So, that's a big category there, big wide swing, but that's a lot of money. Also, there's loss of productivity, and then economic impact from the World Obesity Federation estimates that the global economic impact on obesity will surpass $4 trillion by 2035. So this is a worldwide problem and one that we experience right here in Lubbock, Texas. Some of you may have saw this last week. So last week, the U.S. Surgeon General issued this warning about alcohol. All my residents are getting nervous about this right now. But this warning about alcohol said, hey, we need to maybe put a label on all of our alcoholic beverages to say this may cause cancer. And as I was reading this, I was kind of thrown off by this one little line in here. And so for you all, just raise your hand and or maybe just shout out, what's the number one kind of cause of cancer, would you say?
Tobacco.
What's the number two, would you say?
Obesity.
Obesity, right? And he just kind of fumbles over it here, just nonchalantly in this. He says alcohol consumption is the third leading preventable cause for cancer in the United States after tobacco and obesity. So it's not often that we think of obesity in these kind of dire categories, but it is. It's a huge financial weight on us. It's also a huge burden on our health. So a very, very important problem overall. So what should we do, right? So we should eat less and exercise more. It's easy. And I wish it was this easy, because this is kind of what got me kind of involved in obesity medicine in the beginning. As I went through medical school and residency in the first parts of my practice, I felt kind of like I didn't have very many tools to use to treat weight. And this is kind of what I told patients. I told patients, hey, let's eat a little less, let's exercise more. And then when you get to a BMI above 35, we'll send you to the bariatric surgeon. That's kind of the way it rolled, right? So there's other things that we could do and should do and view patients in a way that we can help them out more. But it's complicated. This slide up here shows kind of how complicated it is. We need to look at the pathophysiology behind eating and weight regulation. It's not only these hedonic influences that cue us to want to eat, but we've really, over the last 50 years, figured out that neurotransmitters and hormones tend to drive our desire to eat. And the way that I've tried to develop my thought process on obesity is to use each one of these hormones or a drug that affects these hormones as kind of a lever that I can pull to help someone with their drive to eat more or drive to gain weight. We're going to kind of dive into some of these slowly. So this slide I just wanted to put up here to show you guys how easy it is. You know, how simple the algorithm is. You can just slide through any one of these and figure out exactly what drug to put people on. No, it's a mess, right? So if anybody up here could tell me what these are really talking about, then you're probably far beyond me in understanding the hormones behind weight gain. But we're going to try to decipher it for you. So ghrelin itself. Ghrelin is the only hunger hormone that we know of. It's the only orexigenic hormone that we've been able to find, right? So it stimulates a certain part of the arcuate nucleus and the lateral hypothalamus. Interesting enough, a vagotomy can decrease the amount of ghrelin that you produce. It decreases or increases gut motility and decreases insulin, and then stimulates you to eat. If you think back to your patients, maybe that if you've had one or two that have Prader-Willi syndrome, one of the things about it is that there's this excessive amount of ghrelin. It's also mainly produced in the gastric fundus. It's why a gastric sleeve is often so fundamental or so powerful in controlling someone's hunger drive, is because that's the part of the stomach that's removed in a gastric sleeve. When the stomach's empty, ghrelin secretion's increased. Levels are high prior to meals, and then they go down after we eat. And when the stomach is stretched, ghrelin's inhibited. So ghrelin going up makes people gain weight. Going down makes people lose weight. Also, if you don't get enough sleep, sleep deprivation increases ghrelin secretion. So all these hormones that drive whether you're hungry or not, you'll notice that poor sleep affects them to this weight positive distribution. So one of the fundamental things you should look at for someone who's struggling with their weight is how well do they sleep? Is obstructive sleep apnea an issue, or are their habits in general just poor? Next up really is leptin. Leptin was one of the first hormones that they really started looking at and really wanting to focus on. Leptin itself, we don't have a drug really that specifically gives you more leptin. They've looked at that, and there's some thought behind the studies behind it, maybe show that there's some leptin resistance. But what leptin does is it's the opposite of ghrelin. As leptin goes up, ghrelin goes down. As ghrelin goes up, leptin goes down. Discovered in 1994. If we go back to our case and think about what this lady was started on, she was started on, do you guys remember? Phentermine and topiramate, right? So two common medications we use. Phentermine, this is how it works. It affects leptin. It releases catecholamines, which then enhance our action on leptin and then bind that area in the hypothalamus. So that's the actual pathway for it. Leptin resistance, like I mentioned, leptin deficiency can cause obesity. It's been documented to cause that. However, if we were just to take leptin levels from people that are overweight, what you're going to find is often it's surprisingly high in those patients. And there's a big thought, just like insulin, we develop a resistance to it. Leptin, maybe we do as well. Okay, so some more exciting things. This is why everybody wants to talk about obesity now. GLP-1 medications. These are the cool things that you see on your TikTok and whatnot. So these are secreted in the L cells of the small intestine, discovered back in 1987. And these enhance that POMC pathway to release AMSH to suppress hunger in general. They actually increase insulin secretion. So that's a little bit backwards than what some of you guys may think as far as insulin driving hunger. Insulin iatrogenically causes people to gain weight. The actual effect on the hypothalamus is to decrease hunger. So GLP-1 actually increases that initial effect of insulin, slows gastric motility. Also, GLP-1 naturally produced in your body. If your sleep sucks, it's going to be low levels as well. It's broken down by DPP-4. Does anybody remember the old DPP-4 medication? Yeah, we still use them every now and then. They're not near as effective, but this was kind of a precursor to GLP-1. GIP, so gastric inhibitory polypeptide. It's secreted in the K cell of the duodenum and the proximal jejunum, discovered way back in 1969, and initially thought to increase gastric secretion, but we figured out the effect is really kind of minor. The major role really has to do with stimulating insulin secretion and helping out glucose levels, and it augments GLP-1. We've got other hormones. I already kind of mentioned insulin and PYY. Both those are regulated or changed by topiramate. So if we think about our patient, she was on phentermine and topiramate. These are working synergistically to help her lose weight. So, like the goal for us all is to think about patients in a weight specific mindset. And if you can, as you see your patient and they start to talk to you about their weight, kind of picture this and picture this as a way to pull levers on your patient to help them lose weight. What I'm trying to do is try to increase GLP-1 for a patient, or make sure that leptin is optimized, or decrease ghrelin, or increase GIP. You're trying to use each one of those as a tool to help the patient find a new body set point. So what tools can we use then? How do we treat obesity? Thankfully, we don't have to get everybody kind of to the beach body, right? We're not trying to get everybody to the six-pack abs. We're going to see better benefit or better metabolic health when someone loses 5 to 10% of their weight. So that doesn't sound like a lot, right? I mean, there's if we have patients that come in and are in that 200 to 300 pound range, we're talking about 10 to 20 pounds here. That's not a big ask. So moderate weight loss to is defined as 5 to 10% reduction in your baseline weight associated with clinically meaningful improvements in obesity-related metabolic risk factors and coexisting disorders. A 5% weight loss improves beta cell function and sensitivity of the liver to insulin itself. If we go more weight loss, so this study here was done on bariatric surgery, and it said mean losses of 16 to 32% from from your baseline weight produced by bariatric surgery in patients with severe obesity may lead to disease remission, including remission of type 2 diabetes in those patients. We can now get to the point where some of these newer medications that we'll talk about can get people to the point of disease remission. I had a patient ask me today, hey, well, what if I keep taking this medicine and put my diabetes in remission? Will my insurance stop paying for my medicine? I said, I have no idea, but let's not keep that from that being our goal, that we should put you into remission of your diabetes. Significant reductions in all-cause mortality have been shown in observational studies in patients that have had bariatric surgery. So we're not just talking about morbidity, we're also talking about mortality with this. So treating obesity and reducing these comorbidities is fundamental. So really what I do is I try to view it in just these 3 easy steps, and any of you residents that have rotated through me in my obesity clinic know this. We try to view the patient in a weight management mindset, and I'll kind of unpack that in the next few slides. And then we try to offer some additional weight loss medications or send them over for surgery. The weight loss medications are not a panacea. They're not going to fix everything. There are some patients that we should probably just refer directly onto bariatric surgery. There are some patients that we should try something besides medications, but we need to stop and think what the best call for that patient is. And then this is probably the most important thing right now, I would say. Follow up with your patient. These medications and weight loss are a constant fad. They are a constant thing that blows up people's social media, blows up magazines, whatever. The thing that separates what we do from what other online shops do or what the kind of doc in the box does is that we follow, right? We join the patient's journey on achieving better health. And that's what makes us much, much different and much better at what we do than other people. So what about this weight management mindset? It's pretty easy. The first thing you should do is just take a history. Take a weight history. So what I mean by that is don't walk into the room and tell someone, hey, you're morbidly obese, and see what happens. That's never going to pan out well for anybody. So what you need to do is walk in and just openly ask, tell me about your weight loss journey. I can guarantee you that every person that comes into your office that struggles with their weight is going to have some sort of story behind it and knows that they're overweight. That's just a standard. Everybody has, the majority of us have a great perception of where our weight sits and would be able to tell you, yeah, I struggle with my weight. So start by already at the point where they know that they have a weight problem, and then ask them what they've done in the past. And then also screen all your patients. For years in our own clinic here, we really didn't put BMI down as one of the vital signs. We put weight down and height down, but that's not as meaningful as a BMI for you. So if your clinic isn't currently screening and writing down BMI, do it. It's an easy way to just see where your patients fall. If your clinic's like ours, 80% of your patients will be overweight or obese. And then ask about recent weight gains and weight loss. A lot of times these patients have already been through a large journey with somebody else. I have patients that come in and tell me, I've met with a dietitian or a nutritionist 5 or 6 times. I've been on these 10 medications. I already had bariatric surgery, all sorts of different things. And so to meet them where they are, as opposed to just unpacking all these, is a great way to start. Set that specific goal. So weight loss to 3 to 5%, like I mentioned, exercise of 150 minutes per week. That's moderate exercise. So what I mean by moderate exercise is you can continue a conversation with someone as you're doing that exercise. Use your motivational interviewing techniques and then develop a plan that addresses potential barriers. So all of these things we've done to help address someone's weight and talk about someone's weight, and we haven't even mentioned a medication, a pill, anything. We need to be able to understand that weight issues aren't only hormones. There's other things involved, but hormones play a huge part of that. And we need to use all these tools to help us treat people's weight. And then use that 5A obesity counseling that Gabby talked about so well. So assess the patient, give them some advice, get the patient to agree to the plan, assist with something, and then arrange a follow-up. So some tips of the trade here, right? So what medications make it worse? Well, if you're watching this and you're an internal medicine doctor, this is all your medicines. This is what you put your patients on, right? So nearly every medicine, a lot of medicines cause weight gain. So we're talking about antidepressants, your SSRIs, your tricyclic antidepressants, atypical antipsychotics for sure, anti-epileptics. So everybody's oldie goldie here, gabapentin, is really not for diabetic neuropathy. The FDA doesn't say that it's approved for that. It's really an anti-epileptic, but we use it for that. And it causes weight gain. Ironically, a lot of your diabetic medications cause weight gain. So your sulfonylureas do, your pioglitazone does, your iatrogenic insulin does. And then, of course, beta blockers, Dr. Shermer's favorite, those cause some weight gain. Antihistamines do, steroids will, so many different things. So as you're viewing your patient, one of the things you should start to look at is say, well, how can I switch these medications around to something that's a little more weight neutral? If I've got someone on an antidepressant SSRI, can I switch them to bupropion, which helps you lose a little weight? If I've got someone on insulin, can I start the GLP-1s? You're trying to shift your thoughts about their weight and their medications to help them to lose weight and kind of break this cycle that we create. If you've got a patient that came in and was newly diagnosed with diabetes and had a hemoglobin A1C of 13 or something, for sure you're going to put them on insulin, right? And then they're going to complain to you about diabetic neuropathy, and you're going to put them on gabapentin. Then they're going to tell you, you know what, my pain's not really controlled with the gabapentin, and you're going to start them on an SNRI. And so as you take care of that patient over the next few years, you will see that patient will start to gain weight and continue to gain weight. And then their insulin resistance gets worse. And it just causes this kind of snake eating its own tail, this cycle. Okay, so are weight loss medications that FDA approved for long-term use widely prescribed? Would you guys say that this is a yes or a no? No. Somebody said no. Okay, sure. Yeah, no, probably not. Right. So for a number of reasons, physicians don't like weight loss medications. There's a reason why of all the physicians at the Health Science Center, there's only a few people that focus on weight, and it's because it's maybe not the funnest thing to talk about, but it's also because physicians don't use weight loss medications to the extent one might expect given the scale of obesity. It's because there's patients are often disappointed by moderate weight loss, dissatisfaction with the results coupled with requirements to pay a lot of money for the medications. And then there's kind of this short-term response of weight loss medications. So that's sometimes not as gratifying for the patient. Practitioners also still kind of have lingering concerns about safety. There's a lot of docs in the room that probably remember some medication that caused issues and then was removed from the market. Weight gain is common after termination of drug therapy. So a lot of times we still view weight loss medications as a short-term fix, and that's not really the case. It should be kind of a long-term solution. Medications that caused harm. There's probably a lot of people in here who remember Fen-Phen. So Fen-Phen was a weight loss medication that was really, really popular in the 90s and worked really, really well. People lost weight on it. It was phentermine, which is a medication we started our patient on, and fenfluramine. So what we found out is that fenfluramine, the second part of the fen, did cause a lot of issues with heart valves. So it was removed from the market after this kind of groundbreaking New England Journal article came out in 1997. So that leaves a bad taste in everybody's mouth about the drug itself, if it's causing issues. And now everybody kind of has more concerns about that. Every now and then, I have someone ask me specifically about Fen-Phen. Most of the time, they don't remember the drug. Most of the time they say, yeah, I remember a drug that was removed from the market. You know, I don't know if I want to take those medications. So there's still a lot of lingering bias against weight loss medications. Also, orlistat. Orlistat. So this medication, not removed from the market, still on the market. But if you've ever had a patient take this, I bet you they came back and told you a story about it. So this medication has some really adverse side effects. So what it does, it's a pancreatic lipase inhibitor and blocks about 30% of fat from being absorbed. Not really that effective as a weight loss medication, but very, very effective at causing oily leakage to be found in your patient's underwear. So this is a bad medication. I don't personally prescribe this medication. You can get it over the counter at the 60 milligram dose. So you can go right now to Walgreens and buy this and take it. They actually put it in chips, I think, at one point. It was an Ally chip or something. Is that right, Dale? You remember that? Yeah, so you could eat those chips and then have problems for the rest of the day. So bad medication, I don't really recommend this one. But these are two medications that have been around for a long time. And this is kind of what people are walking into your clinic thinking about. So you kind of have to address these concerns and talk about their experience with those medications and then talk about the experiences that they're going to have on a medication you're going to start. Because the medications that we might start definitely have their own side effects, right? Okay, so let's talk about phentermine and topiramate, where we started this patient on. So the combination pill for phentermine and topiramate that was studied is called Qsymia. Qsymia was a pretty interesting trial. It found that these kind of work synergistically together, and we talked about that a little bit. But this medication isn't for everybody either. The best people that it's for are maybe postmenopausal, people with excessive hunger, and then people that have more mild side effects from phentermine. So if somebody comes into your office and says, hey, I have a lot of anxiety, I get really worked up, I don't drink coffee because I get the jitters. This is not someone you would want to give phentermine to. Phentermine, it releases catecholamine, speeds people up. You definitely also don't want to give this to anybody with cardiovascular disease, right? So I tend to give this to patients that are a little younger, don't have any sort of, don't have as high of a risk for arrhythmias, or hyperthyroid, or glaucoma, or taking an MAOI, right? It's a Schedule 4 medication, so you need to warn your patient about that. And then probably most importantly about the topiramate is that it's a category X. Right? So that's why you would want to give this medicine to someone who's maybe postmenopausal or maybe to your male that has excessive hunger. This medication you don't want your patient to get pregnant on, so they need to be on some sort of birth control, some sort of contraception. And I think our patient was on oral contraceptive. The reason I said it was kind of interesting, the study of it, is that when they did this initial study, the Conquer and the Equip studies, they looked at really, really low doses of phentermine. Phentermine, one pill normally comes in a 35 milligram. The lowest dose of this mixture of these two that act in a synergistic way, the phentermine's only 3.75 milligrams. So it's really, a tenth, and people still lost significant weight. So on this lower dose, 50% of people lost more than 5% of their weight. So if our goal is to lose 5%, the lowest dose of that phentermine combined with topiramate, we don't have as many adverse side effects from the phentermine, and we get to our goal. Contrave or bupropion naltrexone. So also we mentioned bupropion earlier. These work together as well, and probably would not be a great medication to start our patient on. Does anybody remember why we wouldn't want to start this patient on bupropion?
History of seizures.
History of seizures, that's right. She had this questionable history of seizures. So we taper these medications or tailor these medications to our patient based on their comorbidities, right? So of course, bupropion decreases our seizure threshold, and we would want to give it to that person. But it's a great medication for people that have kind of cravings or more episodes in which they tend to eat the majority of their calories at one sitting and feel driven to eat more. It's great for that. It's great for alcohol dependency as well. With the naltrexone, of course, we would want to avoid somebody who is on opioids. So if somebody's on chronic opioids, you give them the naltrexone, they're not going to like you anymore and they won't come back. This slide just kind of shows this synergistic effect of these two medications. This is that POMC pathway that we talked about that activates our satiety. And bupropion works directly on that. There's this beta endorphin brake that's on this POMC pathway. And when naltrexone's added, it kind of takes that brake off and allows bupropion to activate the POMC pathway even more. Okay, so liraglutide, a great medication. I like this medication, but it's not as effective as you would think it would be. This is our first generation GLP-1, right? So it's the first one that came out. Novo Nordisk, the company out of Denmark, came out with this, and it's a daily injection, giving someone directly GLP-1, but it's not that effective at weight loss. It's been studied for weight loss, and we can give it under the brand name Saxenda directly for weight loss, but it's just not as effective as the other GLP-1s. Still has the same problems, though. If we look at medullary thyroid cancer risk and MEN type 1 or type 2, those are both things that we want to ask our patients about. With medullary thyroid cancer, I have a lot of patients that come in and ask, hey, you know, I had papillary thyroid cancer, or I have a thyroid nodule. Can I take this medication? And the answer is yes. The risk with medullary thyroid cancer was only found in the mouse model. It's never been documented in a human. So I still have that conversation with my patient, and I tell them that, so that way they can make the decision and understand their risk. But it should be just fine for them to take it as long as they don't personally have a history of medullary thyroid cancer or their family doesn't have a history of medullary thyroid cancer. This was the study on liraglutide, and I'll probably go quicker. So I got 5 minutes. Okay, and it didn't show great results. People lost some weight, got to that initial weight loss, but there were better things out there. So better things out there. Novo Nordisk came out with semaglutide after the STEP 5 trial, a 68-week trial. I have no idea why they did 68 weeks, but that's what they chose. And people lost significant weight with this. Major side effect is really nausea, vomiting, constipation. It slows down your gut motility and causes some issues with that. America not to be outdone, right? We're never going to be outdone by those Denmark people, right? So Eli Lilly comes out with tirzepatide. So it's a GLP-1 and GIP receptor antagonist. They added the GIP component to it. People lost more weight than they did on semaglutide. They did a 72-week trial. These can be given in non-diabetics. They're great medications. Same risk and side effect profile really as semaglutide. When you look at other awesome things that these medications do, there's cardiac and renal protective effects, right? So kidney side of things with semaglutide, it's going to slow CKD, reduce albuminuria. It's going to decrease our cardiovascular events, helps out blood pressure some. Tirzepatide does it better than semaglutide, but semaglutide does it really, really well. Stuff that's coming out, right? So Eli Lilly, again, not wanting to miss out on the market share. They've ratatrutide, I guess is how we're going to say this, or triple G is what it's called on some websites, because it uses 3 different receptor agonists. It uses a GLP, a GIP, and a GCGR, which I guess stands for glucagon receptor. There's even more impressive weight loss with these medications. So in that 68-week trial, there was about an average of 15% weight loss on semaglutide. Tirzepatide in that 72-week trial, about 20%. And then this new medication that might come out on the market in 2026, it showed at 48 weeks, they published in New England Journal, a 24, almost 25% weight loss with it. Okay, one thing that I'll say about GLP-1s, they're terrific. They have real side effects. People get nauseous. They do have motility issues. Also, they're hard to find. So when something's hard to find, I always feel like we as humans create a solution. And the solution, I think, isn't that great in this case. This is compounded GLP-1s. They were approved under the pharmacist's ability to compound medications in the event of a medication shortage. So semaglutide was under a medication shortage. So was tirzepatide. But just recently, the FDA kind of removed that shortage from tirzepatide. So I think those compounding pharmacies will start to go away. Also, I don't think there's follow-up with them as well as there is with your primary care physician or a weight loss specialist. So I try to steer my patients away from that direction. Okay. I did it. Your turn.
Okay, so we're going to move on to the second follow-up, which this one was going to be virtual, but the patient reports good tolerance of her new medication, which was semaglutide, and she's continued to adhere to a low-carb diet with the intermittent fasting still. She's also continued to meet her exercise goal of 150 minutes a week. Reports compliance with her CPAP. She does have improved sleep and a decrease in her headaches. Her BMI has significantly decreased from a 31.8 to a 29.5 over the course of a month. And it was discussed setting a new goal to achieve a BMI of less than 27 over the next 18 to 24 months. Her dietary modifications and exercise regimen was also reinforced as well. Oh, I'm going back. Okay, there we go. So telemedicine application here. Follow-up visits can be easily scheduled virtually in order to help with, patients who can't regularly make it to the office due to various number of constraints. Some people may not come today because of the weather, but telemedicine can offer a solution to sort of obstacles such as that. And this improves the patient's adherence to progress visits as well as having good communication with their physician. So in summary, this patient has demonstrated excellent progress with adherence to dietary and exercise recommendations, resulting in improved BMI and energy levels. No medication side effects were reported, and her adherence to the plan was encouraged with a new long-term goal that we discussed about getting that BMI under 27. So we'd like to go ahead and thank Dr. Drew Payne for presenting today. He gave a very interesting lecture. So I'd like to present to you this challenge coin. Just set for you.
Thank you.
And I believe that concludes today. I don't know if Matthew, you want to come up?
Yeah, and if you haven't already, please make sure you signed in at the front. And then everyone needs to kind of text this number, line 39532, just to make sure your attendance is noted. And you will also get an evaluation link. These evaluation links are really helpful for us to make these presentations go on and apply for grants and continue funding. So please text claim 39532 to that number, 844 number, and make sure you're signed in the front. Thank you again to Gabby and Dr. Payne for presenting. We have 5 minutes or 10 minutes for questions right now, so we do have some. Yeah. And if you have any questions, you're welcome to kind of announce it out loud. John?
Quick word on oral semaglutide.
Yeah, so the oral semaglutide is also been shown to help out with weight loss as well. I tend to find patients that are a little have a little more compliance issue with it because it is oral pill and doesn't have that once weekly kind of dosing. I feel like that once weekly dosing helps out the patients a lot, but it is out there.
No, it's an injection.
What's that?
You
Oh,
know it's an injection.
yeah, the injection, ironically, it seems like I mean, I've never really had a patient that wouldn't do it because of the injection. There's an initial fear, obviously, of the needle and doing it, especially if they've never done the injection. I normally walk through that with a demo pin or a sample in the clinic and then give them their first injection while they're there. And after that, the patient doesn't have much of an issue. The needles that come on the Ozempic pen or the Wegovy pen is actually smaller than the insulin needles. So they're very, very tiny needles, for sure. Dr. Nugent, yeah.
Do you know if, does alcohol have a metabolic effect beyond its calorie load?
I don't know that off the top of my head. I know it's classically called empty calories. I would say that alcohol definitely drives this inflammatory process and affects affects pathways that drive weight gain. So any type of inflammation that's there or that baseline inflammation is going to cause all sorts of metabolic changes. So I would say yes, but I don't know really. I don't really have any data or studies to support that.
It increases free fatty acid availability to the liver, tends to make the liver fat laden, and that's the mechanism by which it increases triglycerides and worsens insulin sensitivity. Does all of those things.
Yes,
I'm
sir.
learning daily about my plant-based diet. Should I be on a plant-based diet?
Well, there's more and more information always about diets. I think diet guidance is especially hard to give your patient. I talk with them mainly about simple education about macronutrients and understanding what macronutrients are. I also recommend food journals. The reason I recommend food journals, at least for a couple weeks, is because it's surprising what you eat, right? You realize, one, I eat more than I think I eat. And then two, you realize that a banana, even though considered the healthiest snack, has sometimes 50 grams of carbohydrates in it. So there's these things that, especially my pre-diabetics or insulin-resistant patients and diabetics don't realize that they're eating, causing high blood sugar. So I recommend that for sure. And then for patients that hate that, because a lot of patients don't want to journal everything that they eat, there's more and more information about intermittent fasting. That's kind of in my opinion, kind of a simple, dumbed down diet, so where you don't have to think as much about what you eat, but think about time-wise of what you eat. So, yes, in the back, sir.
When I prescribe either Saxenda or Victoza or Ozempic, it usually gets rejected by insurance companies. Is there any recommendation for non-diabetic patients, specifically for patients that have morbid obesity, hypertension, things like that? I've tried to.
Yeah, our plan shouldn't be wait until you get diabetes, right? So the question was, what about these patients that don't have coverage for GLP-1s? So GLP-1s, what I do here, the trick or the hack that I've figured out is that we have some really good programs here in Lubbock. And I don't know if this will work for everybody that's listening, but here in Lubbock, we can utilize the UMC pharmacy, which is a 340B pharmacy. There's a few 340B pharmacies across the city. But once they've established with that 340B pharmacy, then they can then begin to receive medications at a very discounted rate. So once they are able to do that, then you can get a Ozempic pen for about $270. So that Ozempic pen, $270 a month is maybe more than most people can afford. But you can utilize a thing called click counting and measure out the dose just by the increments on the pen. So I tend to order my patients the largest pen that they have. So the 2 milligram pen, and then we count the clicks, and that's a way around it. So we've got a sheet that we give out in my clinic, came from Cook's Children's. Cook's Children's uses click counting for their kids to decrease side effects, to make their medication last longer. So it's definitely off label, but it saves money.
I have a question.
Yes, ma'am.
So how long do we have to give this GLP agonist, and what are the reasons that they have to stop that medication? Which is nausea, vomiting, do you stop the medications and all of them, or how do you decide on stop?
To stop the GLP-1? So when the FDA looked at that study, it was a pretty long study, right? So one was 68 weeks, one was 72 weeks. So they really looked at it for long-term use. And so long-term use in my mind means we can continue it as long as we need to. So if they are having metabolic benefits while taking the medication, I continue it. So just like my diabetics would continue it to help to control their hemoglobin A1C. If they get to the point where they're back to normal weight, or sometimes I've even had people kind of start to teeter to the lower side of normal weight with those medications, then I have a conversation with them of what do you want to do? And the pharmaceutical reps will tell you there's a point after a year to 18 months where all those hormones that I was talking about, all those proteins start to set a new weight point. And maybe coming off the medication, you might gain some weight, but not all your weight back. But that's a conversation you have to have with the patient. Patients just based on their experience will do different things like decreasing their dose or going to a once every week dosage or something like that. But there should be a point to where you have a conversation with your patient of decreasing their medications. The other thing I didn't mention is that as things go into remission, so like say diabetes goes into remission, or they start to lose significant amount of weight, you will see your patients come in and need all their other medications adjusted. So everything from their thyroid medication, blood pressure medication, all those things will need to be adjusted because they will start to run into issues. People will start to say, hey, my blood pressure is running low. And that's a great thing, right? Great thing is for us to really get people on the fewest, healthiest medications.
Do you integrate a multidisciplinary approach, and if so, what are the disciplines that you would consider?
Yeah, so we've worked hard to try to get physical therapy and occupational therapy involved, psychiatry or psychology involved. Then we have our nutritionist to refer into, and of course our bariatric surgeons. So more and more institutes are being led by weight loss institutes are being led by an internist or a family medicine physician and the bariatric surgeon to work hand in hand to take care of these patients in the whole continuum.
Thank you, Dr. Payne, for excellent presentation. And that's a good segue on multidisciplinary, being a surgeon. We have Dr. Vinay Goyal, our bariatric surgeon in-house, that's probably working with you with the effectivity of the GLP in decreasing weight loss. However, there's really no proven data about the durability, of the weight loss. When will you put the bariatric surgery in the algorithm of all this?
Well, so I still follow the BMI recommendation. So if their BMI puts them in the category that they qualify for bariatric surgery, I offer them that referral right then because we have more evidence on bariatric surgery. I still run into patients that say, I'm not ready for surgery. Or I run into patients that say, I've already had the surgery, or something to that extent. So those decisions have to be made based on the patient themselves. There's still also a lot, if we think there's red tape behind a GLP-1 prescription, there's so much red tape behind having bariatric surgery. So insurance companies will for sure make you jump through 100 hoops before you get there. Dr. Goyle's office is extremely good at helping people through that. That's what they do. Those are kind of some considerations there. I think it's fundamentally important for us to, as weight management specialists, to talk all the time with the surgeons about what they want to see and what type of patients they have. There's also kind of this segment of people that use GLP-1s to lose enough weight to get to a qualified, a bridge kind of to get to surgery. So it's a good thing. It's really how we should approach it.
And the utility of GLP goes beyond weight loss now. I'm a trauma surgeon, and apparently because of its anti-inflammatory effect, it's being used now, in some trials and experimentations on how you could modulate the immunomodulations in trauma patients.
I've seen trials about MS, all sorts of anti-inflammatory. So, okay, thank y'all.